Okay. Okay. Well, thank you very much. It's really an honor to share these 2 days with you all in this important discussion. It's been a very stimulating discussion for me, and I hope for all of you. I am going to make a very brief statement about this topic from an HIV/AIDS perspective, which is what dominates my thinking. We have joined together with UNAIDS, UNICEF, CIF, Elizabeth Glaser, Pediatric AIDS Foundation, and others, really a whole slew of others, to strengthen our ability to identify HIV-positive pregnant women, enter them in a staging process that determines if they are carrying an opportunistic infection that needs to be treated, and if not, begun on antiretroviral therapy. The ability to find women, just to kind of place this in a quick perspective, has been very difficult. To keep them and retain them in care over time, to stage and initiate antiretroviral therapy, and then to follow that woman through her delivery, be attentive and responsive to her needs during that critical 24-hour period. Post-delivery, to identify the status of the child and to continue that child on cotrimoxazole, as well as initiation of antiretroviral therapy within a 7 to 10 day period. And then to take that HIV-positive mother on antiretroviral drugs and continue her on those medications for the duration of her life. That type of service continuum of services and the potential for significant drop-off at each one of those stages has been an extraordinary challenge that I know has challenged each of you in your respective countries to complete those continuums and to retain those individuals and services, both the mother and the child. We have spent the last year and a half better understanding the complexities of these relationships, the medical delivery systems interface with transportation systems, and a 24-hour, 7-day-a-week capability to respond to emergent needs, linked to blood safety issues, transportation of blood as well, and that whole orchestration that just so carefully, frequently shows kind of like the canary in the cage. The vulnerabilities in a medical delivery system frequently manifest themselves in the maternal and child health continuum of services. The 390,000 children who are born HIV positive each year, to give you a snapshot, in 2011, PEPFAR program tested 45 million people to identify 660,000 HIV positive pregnant women. Of those 660,000 HIV-positive pregnant women initiated on antiretroviral therapy, we were able to prevent 204,000 children from being born HIV positive. I say that to give you a feel for how large this issue is, to find a relatively small number of individuals who can easily benefit if the services match up with the right individual at the right time. What we're going to do today is talk about some of the strategies that individual countries, organizations, and industry have put into play to try to help address some of these inconsistencies and potential drop-offs in the continuum of services. I'm going to just briefly introduce Carole, who's going to speak here first. Carole Presern has worked as director of the Partnership for Maternal, Newborn, and Child Health, PMNCH, since February of 2011. Dr. Presern is a midwife and an anthropologist who also has a doctorate in public health policy and qualifications in health systems management. I know many of you have known her for many years. She's a citizen of the United Kingdom and has worked for some 30 years overseas in countries such as Nepal, Pakistan, Zimbabwe, and currently in Geneva. to set up a partnership from the Global Alliance from the Vaccine Initiative, where she worked most recently as the managing director and previously as the director of change management in external relations. So I will turn to her to give a comment. Thank you.
Thank you, Eric and everybody. I wasn't the managing director. I was the managing director, but it's a Gavi quirk. The Seth is actually sitting here, the CEO. We were under him. So, yes, somebody said earlier, bring on the midwives. Well, here is one, and I know there are several others in the audience. And what are we talking about? Midwives need a team. Midwives need pediatricians, neonatologists, and everyone else. But what we're talking about here is essential interventions and the continuum of care. Now, I've been around this business a while, as many of you have. You know, what's the history of integration? We were talking about health for all. Then we went into a phase of more sort of vertical, I don't like that word, and it's not fair always, but more vertical funding. We moved more then to universal health coverage and health systems approaches. But are we doing it right? We heard from people in the morning that we're still not funding what saves lives. But we do know there are proven, costed, and scalable interventions which can save lots of lives. And we heard about how 75% of preterm births could be saved just with some very simple interventions which don't even require any technology. So I'm going to talk a little bit about the why, the what, the where, and the how. And I'm going to retitle this, which Tools for Delivering the Promise gave me some imagery of carpentry or car mechanics, and talk about sort of recipes for success and sort of cooking the cake, if you can follow me on that one. Okay, can I have the, we've all just come out of lunch, so that's a good thing to, oh, am I meant to switch it? Whoops. Talking about essential interventions, and I'm technically illiterate. Okay, that's not working, sorry. Oh, that did. Now I've got to go back. Okay, the context. We know why we're all here. We've heard it from people much more eloquent than I yesterday, but if the population of Switzerland or Burundi were wiped off the map tomorrow, I think we'd be hearing about it all day, every day. And alongside those many, many children, we of course have got their mothers and families and communities that are affected. I am not good at this stuff. Do you want to see if it doesn't seem to be responding? Anyway, I've got my slides in front of me. The continuum of care we've heard about from many, many people yesterday and today. It sort of conveys two things. It conveys time and space. So you've not only got to be looking right across from the pre-pregnancy, and indeed many women may not want to have families, but right through the birth, the postnatal, into having the infant. And PMNCH itself was sort of set up around the continuum of care, recognizing that we really could not be doing anything in isolation, and to really have success, we had to take a population-based approach. So this is about these sort of coalitions and sort of critical connections. People have seen this morning the countdown, and yesterday, oh, whoops, got my slides in the wrong order. Okay, another thing about the context, but Flavia mentioned it, so I'll dwell on it only very briefly. The global strategy, which of course all of you have heard about, and the Every Woman, Every Child effort made one of its most critical centerpieces, looking at essential interventions. What are all the things we have to do along this continuum of care? Next one. And it's there sort of diagrammatically represented, and you can all look at it on the websites. Next. So the countdown showed us today what is the problem in terms of sort of interventions and how they're being implemented or not. I think what I really want to illustrate from this is how many opportunities we're really losing. The one thing many mothers will do, and we all know this, I was an antenatal defaulter, so I can say, but you might take your child along for an immunization. Are we really taking advantage of every opportunity we have during that visit to make sure that many other interventions are done? If the woman's being offered family planning post-delivery, are we checking if she's anemic or if there are other things that she needs? Is she malnourished? Is the child who's coming for the immunization malnourished? I do know from my clinical experience we often waste those very critical times I've got a slide which I can't show, one of my favorites. It's called Dipping in and Out of the Health Sector. And you'll see very clearly there's this big peak when the child needs to get its first immunization. Could we be doing a lot of other things at that time? Next one. You all need binoculars, I know, because I was sitting in the back, and you're not really meant to read it. But the whole point of this slide is just there are great variations in who gets the interventions and who doesn't, based on where they're born, where they're living in the country, and many other things. But the factor that brings this all together is to implement these essential interventions, you need a very strong health system. I'm just showing here, this was about the commitments that were made and where the geographical focus has been in terms of the commitments made around the global strategy, because it does link to the conversation on interventions. Next. So why integrate? I have actually heard at some meetings, and I won't quote the person, we don't have the evidence that integration works. Well, we don't have the evidence that it doesn't. So if there's an information gap, let's fill that gap, but not say, oh, we shouldn't integrate because we don't have the evidence. It's a complete no-brainer. I think if you're a mother or a child or indeed a man, and I've got several facing me, when you walk through a door to get a service, you don't want to have somebody at the other side say, okay, it's the MDG 6 day today, so I'm afraid if you've got a child health problem, you've got to go somewhere else. I mean, we know it's a sort of no-brainer, but do we always really take it on as we should and internalize it? Across this, I will get to the essential interventions, I promise. But when you get to the essential interventions document, which is up here, I really do want to highlight it because I can take no credit for it, so that's always a good thing. But many, many people in this room spent about 3 years, I believe, combing through 50,000 research articles, going through every single piece of evidence, using the Cochrane sort of framework to say, okay, do we know it's a very strong evidence base? Is there a strong evidence base, but we got gaps? Is there no evidence? Is it above all cost effective? Are we doing the right things? So this came together in a meeting, I think it was November last year, where led by the World Health Organization, Aga Khan University, and about over 40 partners, a consensus was eventually reached. Any of you who are academics with sincere apologies, but you can imagine getting consensus from a group of academics was worse than watching paint dry, but it did eventually dry. And I have the document here. It is outside near the reception desk, and I really urge you as recommended reading. I can't go through it, but there are 7 key groups of interventions. Within that, there's 56 different things that we need to do. There are some things we don't yet have the evidence for, and the researchers in the room, we'd really like you to go off and see what needs to be done to fill these gaps. And on some things, we don't actually need the evidence. I'll share a bit of personal information. I've had 2 postpartum hemorrhages. I don't want somebody telling me we haven't done a randomized control trial to tell me that I needed a blood transfusion. So there's different sets of interventions and different things we know for sure and we should be doing. Next one. This is actually an eye test, and you'll be tested afterwards. But as Eric said in the morning, sorry, I'm very jet-lagged, said just now, how do we really, for example, on the antiretroviral thing, how do we make sure we don't get that drop-off? And I think looking at the sort of continuum of care approach, looking at all the interventions and contacts people will have at a health service, you see there are multiple entry points, and we really should be maximizing on this. So what next? Somebody else I heard this morning said a document's only as good as what you do with it, and I could not agree more. I would not be involved in any of this if I didn't think we could actually take it to the next step. And as Amy and others said this morning, it's about the why, the what, the how. So how do you get to this scale up? We heard that there were lots of countries, well, not lots, sadly, but some which even with quite difficult economic, political, and social environments still have been able to scale up these interventions. How do we take those examples and really replicate it? We do have some plans to get this very well disseminated. It is a dynamic document. We will come back. We will invite feedback from everyone on how it could be refined and made better. But we want to now get to the stage of how do you move this into policy, how do you move it into the changes and action, and how do you move it into practice? Because like I started off with the slide on Switzerland, Burundi, and you could have chosen several other countries with similar population bases. We would just not accept it, and we shouldn't be accepting it anymore. And I'm very grateful to USAID, UNICEF, Ethiopia, and India for putting this spotlight on the child, but recognizing that the child is part of a family, community, and society. We know what we can do, so let's do it. Thank you.
Thanks, Carole. Thank you. That was good. That was good. Okay. Our next speaker is Ms. Holly Newby. She's a senior advisor in statistics and monitoring at UNICEF headquarters in New York. She leads the team responsible for maternal and child health and nutrition data, and she's the UNICEF focal point for global monitoring for MDG 5 and 6. Ms. Newby is an author of Pneumonia and Diarrhea, Tackling the Deadliest Diseases for the World's Poorest Children.
Thank you so much. So as I hope you all know, last week UNICEF released a new report that you should have received in your folders, Pneumonia and Diarrhea, Tackling the Deadliest Diseases for the World's Poorest Children. I'm going to present some highlights from this report. Earlier today, Bob Black already showed us this cause of death pie chart, but I'd like to highlight pneumonia and diarrhea, which together account for almost a third of under 5 deaths worldwide. This results in a toll of more than 2 million lives lost annually, and this burden is felt particularly in the poorest regions and countries. However, these deaths are preventable, and indeed we have the opportunity to try to narrow the child survival gap by tackling these two diseases. Let's take, for example, Ethiopia and Germany, two countries with among the highest and lowest under 5 mortality rates in 2010. As you can see from the graph, in the case of Ethiopia, an estimated 35% of under 5 deaths were due to these two diseases, compared with less than 3% in the case of Germany. The bottom line is that children in industrialized countries like Germany are not dying from these diseases, unlike children in the developing world. However, we do have the tools to prevent these deaths. We have numerous interventions, well-known child survival interventions from different sectors with a proven impact. For example, we can prevent these diseases through appropriate breastfeeding practices and adequate nutrition, vaccinations, hand washing with soap, basic sanitation, and safe drinking water, among other measures. When a child does get sick, we can avoid death through, for example, antibiotics for bacterial pneumonia, and for children with diarrhea, oral rehydration salts, ORS, as well as zinc. It's important to keep in mind, and it's shown in this figure, that a number of these interventions are identical, and thus integration is essential, and it's really critical to try to deliver these interventions in a coordinated way. So I'd like to give you a few highlights regarding prevention coverage. The world did meet the MDG target on drinking water in 2010, yet we still have an estimated 780 million people who do not use improved drinking water sources, and these people are particularly located in poor households and in rural areas. What you see in this chart is an example of the differentials at the regional level between the populations in the richest and the poorest households. Exclusive breastfeeding for children under 6 months of age is essential. It is fundamentally important, and we know that it greatly reduces the risk of death due to diarrhea and pneumonia. However, in the developing world today, less than 40% of infants of this age are exclusively breastfed. And now just a couple of treatment highlights. When a child has symptoms that are consistent with pneumonia, the first step is appropriate care seeking. Now, the good news is that these household survey data indicate that the majority of children with symptoms of pneumonia in the developing world are indeed taken to an appropriate healthcare provider. On the bad side, however, what you can see in this chart is that there are great differentials according to household wealth, and indeed the poorest children are the least likely to be taken for appropriate care. Among children with symptoms of pneumonia in the developing world, less than a third receive antibiotics. Now, of course, we cannot assume that just because a child has these symptoms that it necessarily means that they have bacterial pneumonia and should receive antibiotics. But nonetheless, we do see that less than a third receive antibiotics, and more importantly, we have a pattern in the data that indicate that it is the poorest children in the poorest countries that are indeed the least likely to receive treatment. Diarrhea. In the developing world, among children with diarrhea, only about a third receive ORS, oral rehydration salts, and we know that even fewer receive zinc. Once again, the data tell us that it is the vulnerable children, those in rural areas, those in poor households, that are the least likely to receive treatment when they're sick. So where does this leave us? In order to tackle pneumonia and diarrhea, we need to aggressively scale up both prevention and treatment measures, especially among the most vulnerable. I'm sorry to say that there is still a lot of work to be done. In the case of treatment, for example, we've seen basically negligible progress over the last decade. But what would happen, what would the impact be if we could actually scale up these interventions in an equitable way? Well, for this report, we actually did a special modeling exercise using data from Bangladesh that indicated that if we were actually able to scale up these pneumonia and diarrhea interventions to near universal coverage, we could actually save about 6 times as many lives among children in the poorest households as the richest. So that's something for us to think about. Fortunately, and many people have been talking about this today, we have innovations. For example, innovations in products, child-friendly dispersible zinc, amoxicillin in appropriate dispensable form, flavored ORS, and of course vaccinations, new vaccinations to combat the major causes of pneumonia and diarrhea. We have Hib, pneumococcal conjugate vaccine, and rotavirus. But more importantly, we also have innovations in terms of approaches and strategies that can help us accelerate progress. For example, the training and deployment of community health workers that can help us to get care to the vulnerable children who need it most. And of course, yesterday we heard a lot about public-private partnerships and how essential they are. The way forward, however, is not just about innovations. It's actually about going back to basics and being able to scale up those tried and true interventions that we know are effective. And so it's time to put pneumonia and diarrhea back on the child survival agenda. I'm happy to let you know, in case you don't already, that there is indeed a multi-stakeholder effort that has been established to create an integrated global action plan for pneumonia and diarrhea control. You should be expecting more articles coming out later this year and a global action plan early next year. So this is actually a very exciting time. And in conclusion, I guess I'd just like to leave you with this thought, that if we are to achieve this goal of ending these preventable pneumonia and diarrhea deaths, we do need adequate financing, but also we need a renewed and even a greater commitment from all partners. The fact of the matter is that we know what needs to be done, we have the tools, and so the time is now. Thanks very much, and I hope you'll enjoy looking at the report.
Nicely done. Thank you.
Holly Newby, sorry. I think what I learned from her presentation was that concerted effort among these different stakeholders are very, very necessary and important. The next speaker is Dr. Shyama Kuruvilla. Dr. Shyama Kuruvilla is Senior Technical Officer, Knowledge for Policy at the Partnership for Maternal, Newborn, and Child Health, PMNCH. In the PMNCH Secretariat, which is hosted by WHO, she is the focal point for brokering knowledge and innovation for women's and children's health. Dr. Kuruvilla works with PMNCH partner organizations on a range of projects, including policy analysis and evidence synthesis to support the implementation of essential interventions and the use of evidence in policymaking. Dr. Kuruvilla, please.
Thank you very much, and good afternoon. The presentation that I'm going to give today reflects the work of many people in this room and who are members of the partnership. As Carole mentioned, there are many constituencies in the partnership with over 400 organizations now. And to start with, the first slide is based on the work of the Countdown, on which we've heard a lot. And this is just looking at progress across the 75 high-burden countries in the Countdown to 2015. So again, it's going to be difficult to read, but there are only 8 countries that are on track for both MDGs 4 and 5A. There are additional 15 countries that are on track for MDG 4. And there's only 1 country that's on track for MDG 5 alone, which is Equatorial Guinea. And so the question then is, why is there this big variation between the countries? And one of the roles of the partnership and in discussions is for the partners to identify evidence gaps that they'd like to address together. And this was one topic that was highlighted at the PMNCH Partners Forum in 2010. And the question was, why are some high-burden countries more effective than others in reducing maternal and child mortality? And so if, again, you can't see this, so I'll just read it out. A group of partner organizations led by the World Bank, WHO, the Alliance for Health Policy and Systems Research, the University of St. Gallen, and others undertook this project. We're using a range of methods to address this issue. Qualitative methods, looking at case studies in successful countries. 5 were selected. These are Bolivia, China, Egypt, Malawi, and Nepal. And some analyses in countries that aren't making as good progress. We're also using a range of quantitative methods. We've used and built on publicly available data, so the Countdown coverage indicators, but also indicators of governance, of gender inequality, of environmental performance, and a range of other issues. And we also looked at using some different methods. And so at the University of St. Gallen, the Department of Comparative Politics is using this particular method that relies on Boolean algebra and has been used in political science a lot, from John Stuart Mill on, actually, in the 19th century onwards, but more recently only in health and development. And so what has been really interesting in doing this kind of a multi-method study is that if a factor had been identified as being significant in the quantitative analysis, the case study component and researchers would say, well, let's now find out why. If we ask, for example, how does education play a role? Then in the case study countries, the question would be, so how did you integrate education and health programs, or how did these two things come together? So based on the first phase of the study, we've identified 4 working hypotheses. The first is that health systems were adapted for specific contexts. So for example, because of the geographical and governance challenges in Nepal, the health systems were community-based and community-supported. In Bolivia, there's a very strong emphasis on indigenous populations and making health services more acceptable by using cultural and traditional practices and linkages. The next element was that in all these countries, the outcomes were monitored with actionable data and local accountability. So there were registration systems, surveillance systems set up, but also audits like maternal death audits and others. There were also health programs that were prioritized, as Professor Black had mentioned in the morning, looking at causes of death. But importantly, these were not standalone Ministry of Health projects. These were part of the national development strategies and plans. And Amy mentioned this in the morning, and Joy and many people since then, that a significant factor was the empowerment of women and children, both through education, but also through social, economic, political participation, and entitlements, which is the rights and resources to have access and use essential interventions. There were some overarching observations that while there might be some global principles for success, each country implemented these in very unique context-specific ways. And this was just emphasizes what we always say, that there's no one-size-fits-all approach. The other issue was that political commitment was absolutely key, and that leadership for progress could come from any sector, not necessarily the government. So as Jay Naidu pointed out, the civil society organizations, individuals as well, maybe a president's wife's obstetrician who catalyzed a movement. And it could be from the faith-based sector as well. For example, in Egypt, how there was a fatwa that family planning was actually permitted in certain circumstances, and this was in the 1960s, and how this facilitated some of the programs being developed. And to mention another more current day example in Egypt, with Dr. Astur sitting somewhere there, there is the National Council for Motherhood and Childhood, which is not, it's an intergovernmental council that works across education, water and sanitation, and health, etc. And finally, we're going to just be able to see the big headings here. Where does all this lead to? So there's this evidence, and the title of this session was about tools to deliver the promise. And I think what's very clear is that the tools are not necessarily something that comes out of academic institutions, but countries themselves have come up and developed and designed amazingly powerful tools to deliver the promise. And as Minister Tedros said this morning, governments learn from each other. And there are lots of opportunities coming up this year, including the call to action. But moving forward, in July, there's a meeting of ministers in health and finance in Tunis to start this policy dialogue. In November in Manila, there will be a leadership and policy dialogue. And the tools that we're looking at are, for example, to assess and define the situation, to design and invest, and these are cross-sectoral strategies, and Gary will talk about the role of private sector engagement, and then about implementing with accountability. And it's wonderful to have events like this where a critical mass of actors and actions can come together to make a difference. Thank you.
Thank you. As we have already run out of time, I'd like to quickly move to the next speaker. I'd like to introduce Mr. Gary Cohen. Mr. Gary Cohen is the Executive Vice President of the Becton, Dickinson and Company. He's also chair of the CDC Foundation, board director of the US Fund for UNICEF, and also advisor to the Clinton Global Initiative, and also a founder of the Together for Girls and the commissioner, UN Commission on Life-Saving Commodities. Mr. Cohen, please.
Thank you, Kobayashi-san, and good afternoon, everyone. So I was one of the people who followed the instructions and dug out a picture. You can see I was in training here to be Austin Powers. I didn't quite make it. This was taken during the jet age in the United States when everyone was looking to the future at the 1964 World's Fair in New York. And my colleagues tell me I have a big head on my shoulders and it must have started at a young age. So I have a privilege this afternoon to share with you information on how to unleash the potential of the private sector for public health and how to align private sector capabilities around the very same health goals that we're speaking about today. And there is actually a fantastic publication that's going to be issued or officially launched in July in London called the Private Sector Engagement Guide. This was created by the Innovation Working Group in support of Every Woman, Every Child, the UN Secretary General's effort. This Innovation Working Group was co-chaired by Tori Godal of NORAD and Scott Ratson of Johnson & Johnson. And the guide itself was developed by the Partnership for Maternal, Newborn, and Child Health, and FSG, which is a nonprofit consulting firm. And what this guide does is it provides a precise roadmap for the private sector. Companies, on the whole, have been less engaged in addressing these goals. And this, from my own experience and being an advisor to the guide, it provides a very precise means to define how companies can become engaged. It identifies unmet needs and opportunities, establishes areas where business can have impact, emphasizes collective engagement through partnership across sectors. It creates an opportunity for shared value, which is a term I'll define in a moment. And it's towards the goal of saving 16 million lives by 2015. So why the role of business? Yeah, I don't think there's that many people in the audience here proportionally from the private sector. What is the role of business? Well, one thing I think we recognize is that no single sector acting on its own, whether it's government or NGOs or the private sector itself, can solve the deeply embedded health problems, and particularly with this last mile that we're trying to climb. Business has very distinct capabilities that enables it to succeed, and core competencies that can be deployed for the purpose of saving women and children's lives. And in particular, if we think about bringing these capabilities to scale and these interventions to scale, if business brings its innovation capabilities, its resources, and its global reach, and does that in a manner that also creates commercial success, it really gives the opportunity to achieve these goals. The other thing is diverse industry sectors can bring unique capabilities. If you think about the difference between the health sector, the nutrition sector, and the telecommunications sector, and what can be done in each of those. And then through workforces in the energy sector and the mining sector, there's a huge amount of potential here. So let me briefly cover 4 different types of engagement that the private sector can pursue. And I'm going to do the first one last, if I will. Philanthropy and corporate social responsibility are traditional means. They're extremely important. Giving things away, giving away cash, giving away in-kind donation of goods, and also using core competencies through technical training and support or other means of corporate social responsibility. Business can have a significant influence on policy, so using its influence for public policy and advocacy around appropriate changes in national laws and international guidelines, and of course collaborating across sectors. But I would submit the most powerful mechanism is probably the one that today has been least utilized, and that's shared value, which is aligning commercial business operations in a manner that's responsive to emerging market needs. This concept of shared value has been promulgated by Professor Michael Porter at Harvard. And anyone who has a business background such as myself knows Michael Porter for at least the last 4 decades. He is the primary guru of business strategy. I studied him in business school. I've been working with him over the last several months. I'm amazed how young he is, given how far back his influence goes. Well, Michael Porter's essential proposition on shared value is that creating social value comes from making investments that address social and environmental objectives. Creating business value is investments that impact long-term competitiveness. In the intersection between these two is shared value, which is investments in long-term business competitive that simultaneously address social and environmental needs. Now, that may sound like a sophisticated way of defining it. It's as simple as focusing the capability of the private sector on helping address these unsolved critical health needs of women and children in a manner that also creates opportunity for them. There are many ways of doing that, and the Private Sector Engagement Guide goes into this in some detail, but in summary, Businesses can reconceive products and markets, can redefine productivity in their value chains, and can strengthen local clusters and capacity. And there's some examples here. You can't read them now, but when the guide launches, I really encourage you to look at the examples that companies have demonstrated in these areas. So I'm just going to go now in closing and say, what is the path forward? Well, this guide is going to launch on July 11th at the major family planning meeting in London. It's been worked on for almost a year. I can tell you this has been done with great care and sophistication. And having had led BD's interventions over the past decade in HIV/AIDS, I can tell you we followed a very similar strategic approach of understanding the specific areas of intervention where we can make a difference. This guide does that broadly across industries, and it's going to be a fantastic resource for companies, and will also give them no excuse but to figure out how to get involved because it's being defined for them. There's also a number of other events coming up for the Partnership for Maternal, Newborn, and Child Health, board meeting in Nigeria, and also a workshop in the Philippines. The fundamental methodology is going to be to select countries, to align objectives across sectors and among partners, and then to work on creating shared value and tracking results. If you're interested in following up on this prior to the publication of the guide, we suggest you contact Marta Seone, who's with the Innovation Working Group Secretariat, and there's also an email address here. So one way of thinking about this, in conclusion, is that 70% of the world's population resides in underserved markets. This is in business terms. And companies that address the needs of these populations are going to be the companies that are going to be here for the long term. It just makes logical sense. And if I put it in, let's say, less business terms, I can put it in personal terms. I tell people that I work with that one day you're going to be on in your last days. You'll be on your deathbed, and you're going to look back on your life. And you're going to determine what were you really proud of about what you accomplished, and perhaps what were you ashamed of. And of course, achieving your business goals is something that was part of your career, and you'll be proud of it. But if you can look back and say you used the potential and the resources of your professional responsibilities to save children's lives, I guarantee you that'll be the thing you're most proud of. So there's a website you can access, and thank you very much for your attention.
Thank you, Mr. Cohen. There were a variety of factors needed for child survival. And what came to my mind listening to the presentations was that we have knowledge and tools, but it's very difficult to coordinate the work on the ground. On the ground, for instance, we have to work with the civil ministries, Ministry of Education, Ministry of Health, Ministry of Public Works, and other ministries. And also we have various partners, donors, CSOs, faith-based organizations. So we have a knowledge and tool, but I think the next step is to work together as a team. Perhaps we can call ourselves Child Survival Call to Action Family. I'd like to ask Ambassador Goosby to give us a few words.
Well, thank you. I'm going to make this very brief because we did go over. I think that the challenge we all have is to look inward, as everyone has basically said, and ask ourselves if we have done everything we can to try to understand the problem, and through that understanding, develop a strategy that is effective, that we identify markers of efficacy so we can monitor impact and ensure ourselves that in the implementation we do not drop off in our desire to maintain and increase the number of people who benefit from the service and increase the number of lives that we save. So I'm going to end with that, and thank you very much. I'd like you to give a round of applause to the panel.